Dr. Reid's up next.
So,
Experience with fenestrated Anaconda device.
thank you. Well, Venkatesh Ramaiah asked me if I would tell you a little bit about what the options in Europe are that isn't available in the United States. And so I thought I would concentrate on just one graft that I've had particular involvement with over the years, and it's called the Anaconda device. So this is John Pollock, and John Pollock was trained in Houston by Dr. DeBakey and by Denton Cooley. And when he came back to Glasgow, he founded a company called Vascutech that many of you must have heard of because it has implanted well over 1 million open grafts in people over the world. And in 1980s, John also recognized that endovascular was coming. He was very friendly with Ted Dietrich from Houston at the time that he was in Houston. And so endoluminal grafting was also begun at the company. It's now been taken over and named Terumo Aortic. So the fenestrated Anaconda device is really for dealing at the lower end of the thoracoabdominal segment for juxtarenal artery involvement. And it's a thin woven Dacron graft. It differs from many other endoluminal grafts because the seal is from 2 metal hoops at the top of the graft. The fenestrations are placed as a custom fashion with CT guidance, of course. It's modular with 2 limbs and a main body. And the first case in the UK or worldwide was by Peter Bungay. Sorry, my slide's gone forwards there, but and he really has pioneered this in the UK. He's a radiologist down in Derby. So a closer look at the Anaconda device is these 2 metal hoops, oversized slightly for the aorta, provide the seal.
That's exactly why.
And the attachment to the delivery system allows redeployment, which is crucial for fenestrated work, where you have to absolutely line up the fenestrations over the origins of the visceral vessels. And the redeployment is simply done using your thumb on the delivery system. Another little gadget which is actually incredibly helpful is this magnet wire. And that gains the contralateral limb section when you're joining up the main body with the contralateral limb. Case planning is done with CT scanning. It does take a few weeks for the elective cases, obviously, to be manufactured by the company. They have a great team of engineers who were radiographers, and they provide us with a dummy model and a resin model that we can, if we want to, practice on before the case using fluoroscopy. The other thing that the engineers do is to make the graft in the main area of the aneurysm across the origin of the vessels either wider or they narrow it, they waste it. So it's called tapering and pleating in order to try to get the origins of these vessels absolutely opposed to the fenestrations to make it easier to cannulate. And so the main body is placed, and you can see here the 2 renal arteries have been canalized and sheaths put in, and here's a covered stent ballooned into one of the renal arteries, and then you trumpet. You use a bigger balloon proximally to make sure of a really good seal for the visceral vessels. That's the left renal, and here is a lateral view just to show the superior mesenteric artery also involved in this case, and a completion angiogram, so straightforward. Sometimes it is better to come from a brachial access in order to gain in order to gain access. You can see here the celiac axis has got a very tight narrowing, and so it was easier to come from above in order to put the cover stent in there. In other situations, other than the straightforward aneurysm, sometimes we will use this fenestrated graft as a cuff for a type 1 endoleak, and over the years that has been a fabulous way of treating patients with type 1 endoleak. The company arranged a registry early on, and you can see the United Kingdom had done quite a lot of cases for this. 628 patients were followed up over the course of 4 years. Most of the fenestrated cases were 2 or 3 fenestrations. And you can see here, in fact, the endoleak rate has been fabulous. You can see sometimes at day 0, 7% type 1, but at discharge and follow-up, almost no type 1 endoleak, and a normal type 2 endoleak. 5% 30-day perioperative mortality in all of these cases, and a visceral vessel occlusion of 1.4% at 1 year. There is now quite a lot of literature regarding the fenestrated anaconda, and the results are very favorable, in fact. Just quickly to compare fenestrated cases with open surgery in the juxtarenal area, there's this very good paper in the United Kingdom from centres throughout Scotland and England. And it's just to show you that the mortality of fenestrated cases versus open repair is pretty similar, 3.3% for fenestrated cases, 4.2% for open surgery. So it is a little bit lighter on the patients. A little bit of problems with renal impairment with contrast on both sides, and the reintervention rate, as usual with endovascular, is higher than open surgery. So it compares favorably well and a little lighter on the patients, obviously. I wanted to finish with what I hope will be a future, and Dan Clare showed you that there are developing true branch grafts to simplify this rather than fenestrations, because it is tedious and a fiddle to try and get through these cannulations sometimes. And this is Miles Douglas's graft that he's developing. He invented the Endologics graft with Dr. Dietrich as a true branch graft. So there are no fenestrations here. The graft is put up over different wires and fed into the visceral vessels. And one hopes that this will be in development and in clinical practice soon. So in conclusion, for the fenestrated endografting around the juxtarenal areas, there are some good results versus open surgery. It's much lighter in the patient, and true branch grafts, I hope, will come in soon. Many thanks.
Thanks, Donald.